Good evening, everybody, and welcome to our World Stroke Day webinar. My name is Neil Johnson, and on behalf of the Heart and Stroke charity Croí, I'd like to thank you for your interest in this evening's conversation. I'd like to thank our panel of speakers in advance for agreeing to participate in the discussion, all coming to us with huge experience of this subject. And I'd also like to pay special thanks to our stroke education partners, Surmodics in Ballinasloe. Delighted to see such huge interest in numbers. We've over 500 people registered for this evening's webinar, and I hope you find it of benefit and it answers some of the questions you no doubt have. You may or may not know that as many as 1 in 5 of us will have a stroke at some point in our lifetime, which is a rather startling number. And stroke has no respect for age, gender, or socioeconomic status. Disturbingly and increasingly, the number of strokes, younger strokes under the age of 65 is increasing. Estimated at about 25% of strokes today are in that age profile. As many as 10% of strokes are fatal, with about 50% of strokes being mild and not resulting in any disability. But unfortunately, 30 to 40% of strokes leave the individual with moderate to severe disability. There's been huge advances in the treatment of stroke, and you'll hear more about that this evening. But an area of great need, and an area which Croí is hoping to engage with in the coming years, is in that phase post-hospital discharge and recovery. And again, we'll probably touch on some of that this evening. So we have a panel of speakers. I'll introduce them. They'll speak, each speaker will speak for about 15 minutes. And then we'll leave time about 20 to 30 minutes for Q&A at the end of the webinar. Unfortunately, with such large numbers, we can't invite you to speak verbally to our speakers, or orally rather. So I'd ask you there's a Q&A button at the bottom of your screen. We already have received a number of questions. And if any question occurs to you, just simply type it in there, and my colleagues will be tracking these questions. We most likely, in fact, definitely will not get to all questions, but we'll try and collate them around general themes insofar as we can. So to kick off this evening, our first speaker is Dr. Neil Hannon. And Niamh is a Galway native. She grew up in Salt Hill, graduated from the medical school at NUI Galway. She's her specialist training in Dublin. She has a PhD in stroke and atrial fibrillation from UCD. And she's worked as a consultant stroke physician in Addenbrooke's, Cambridge, in the UK for 5 years. And now she is a stroke and geriatric medicine physician at Galway University Hospitals. And that includes GUH and Portiuncula. Niamh, thank you very much. You're very welcome. And I'll hand the stage over to you now.
Thank you very much, Neil. I just have some slides here. What I'd like to do with you to start this session off is to try and answer some commonly asked questions about stroke, including what is a stroke? And there are 2 types of stroke, really. The most common one, which is up to 85% of stroke, is the clot type, or what we would call in medical terms an ischemic stroke. And this is a stroke that's caused by a clot that travels usually from within the body somewhere and up to the brain, causing an acute occlusion, allowing a blockage to happen, which stops the oxygen from getting to brain cells. And obviously oxygen is essential for brain cells to function. And unfortunately, once deprived of oxygen, they will die and they will become a stroke. The second type of stroke is less common, but we still see up to 15% of cases having a hemorrhage. This is not formed from a clot, but this is where a blood vessel has ruptured for some reason and allowed blood to pool within the brain where it's not supposed to be. This is a bruise, more or less, within the brain, and this is a bleeding type of stroke or intracranial hemorrhage. What's really important to know for everyone is what are the symptoms and signs of stroke, particularly for yourself or a loved one, because you need to act fast. And many people will be familiar with the FAST acronym. It's been around for a number of years now. There was an advertising program on the TV a number of years back with pictures of people having a stroke. The F stands for face. Has the person's face fallen on one side? Can they smile? A is for arms. Can they raise both of their arms and hold them up there? S, is their speech slurred or confused, not making sense? And T, it's time to call 999 if you see any of these signs. But we're adding a few things to FAST in recent times. We're adding a B for balance. Does that person have trouble with their balance? Are they unable to walk without assistance? And E for eyesight. Have they lost vision in one eye or to one side of their visual field? We would also include sudden confusion, which is unexplained for the particular person, or sudden numbness, usually down one side of the body. A very common question is, am I at risk of stroke, or what can I do to reduce my risk of stroke? And there are many risk factors for stroke, many of which are actually very modifiable, so you can actually take control of your own destiny. High blood pressure is one of the most prominent features in a pattern of stroke risk. And we have very strong targets when we want a person with high blood pressure to reach a better area where they're safer in terms of their stroke risk. High cholesterol is also a very important factor as it causes this abnormal lump of fat to form in the inside of blood vessels, which in itself can cause these clots, which cause stroke. If you have diabetes, it's obviously really important to keep this well controlled. Smoking doesn't take much in terms of a smoking history to put a person at risk of having a stroke. Family history, of course, can play a risk, and people who have a strong history of stroke in their family can themselves be at risk. And a history of heart disease, whether that's ischemic heart disease or angina, or most particularly a history of an irregular heart rhythm called atrial fibrillation. This is actually a very common irregularity of the heart rhythm, particularly as a person ages, but unfortunately it's very asymptomatic. In other words, you can have this and not know that you have it unless a doctor or other healthcare professional takes your pulse and then does a heart tracing called an ECG, and they can see that this irregularity of the heart is there. It increases your risk of stroke of up to 5 times, but thankfully we can protect people from stroke when we know they have this irregular heart rhythm. And that's part of the strategy that we use in patients to lower their risk. This is a medication approach, and many of the approaches to lower people's risk will be medications to lower their blood pressure, to lower their cholesterol, to optimize their diabetes control, and using blood thinners such as aspirin or clopidogrel, or indeed stronger blood thinners if a patient has that irregular heartbeat called atrial fibrillation. Of course, stopping smoking makes a huge difference to your stroke risk, but you can't really change your genetics, so that is something that's not modifiable. But up to 90% of these risk factors for stroke are in fact modifiable, and you can take control of your own destiny. What can you do if you see someone with the FAST positive test and if you think they're having a stroke? Well, it's really important to recognize that they could be having a stroke. You need to pick up the phone and dial 999. And remember that you don't have time to stop and think about what happens next, because every minute matters in terms of a stroke as it evolves. We describe this as time is brain. And in terms of every minute that passes on the clock, thousands of brain cells are lost. And the more time that passes after the stroke, the more brain cells die and the greater the damage will be. And in some cases, it will even put the person's life at risk. It's really important for that patient to access treatment in hospital, because thankfully, unlike previous years gone by where all we could do is put the patient in bed and give them an aspirin, we do have treatment options nowadays. We have a team that starts from the moment that you activate 999. Our paramedic colleagues will recognize that this patient needs to get to the emergency department as quickly as possible. On arriving at the emergency department, they will be rapidly assessed by a team of professionals in stroke, including a consultant, a registrar, and an advanced nurse practitioner, who will activate CT scanners, blood tests, be taking a story and trying to decide if this patient is in fact eligible to have treatment for their acute stroke. What you see on this slide is an example of a CT scan. What we're actually looking for is a reasonably normal picture on a CT, because this tells us that the patient is getting to us early, and it tells us that we can intervene in some way to try and reverse and slow the progress of the stroke that's currently happening in that patient in front of us. There are two treatment options. The first is called stroke thrombolysis. This is a drug which we administer. We call it a clot-busting treatment, and the patient would receive this through a drip. The idea being that it will break down the clot causing the stroke and try and restore the blood flow to the damaged area of the brain. The second treatment has been around since 2015, and it's opened so many doors of opportunity for our stroke patients. It's called thrombectomy, and it's essentially a minor operation that happens in Beaumont Hospital, where a catheter is inserted through a patient's groin, fed up to the patient's brain directly to where the clot is causing the problem. And the idea is that that clot can then be retrieved, sucked out of the patient's head, if you like, and that patient will actually have a restoration of normal blood flow, and hopefully with that comes good recovery. The earlier that patients get to these treatments, the better they will do in terms of disability and of course in terms of the risk of them dying from the stroke. The earlier the better. Within the first 90 minutes is best, but up to 6 hours, we still have an opportunity to intervene. And with modern developments in medicine, and stroke medicine in particular, we can actually now consider intervention up to 24 hours. But I would still urge that these patients come to us as soon as we can possibly get to them. Another question that people often ask in the stroke area is, well, I had a TIA, does that mean that I had a stroke? And I often answer, this is a mini stroke, but this does not lessen the seriousness of what's happened to you. TIA stands for transient ischemic attack. Essentially, it's a stroke which started but did not complete, and the patient has had full resolution of their symptoms, usually within an hour of onset. But it is just as serious as a stroke because it marks that patient as being at risk for having a stroke down the line. So it's really important that a patient who has a TIA seeks medical help. Usually that will be at the first port of call with their GP, who may then refer them onwards to see a specialist in the hospital. Specialists will then work the patient up to try and figure out why this has happened to them and to address their risk factors and reduce their risk of having a stroke, to do a full workup, including looking at their heart, looking at their blood pressure, their cholesterol, and all of those risk factors I mentioned earlier, to try and protect that patient for the future and allow them to live a normal life. So I've addressed there some of the most commonly asked questions, and I know that some people will have more questions, and as Neil has mentioned, we hope to address some of those in the Q&A at the end of this session.
Really superb coverage in a very succinct way and exactly on time. So thank you for that. And absolutely, and even on the basis of some of the questions that have come in already, you've touched on a lot of the areas. So we will call you back again when we get to the Q&A section. So thank you very much. So our next speaker, no stranger to Croí, good friend of ours for many years, Trish Galvin. And Trish has been working in Galway University Hospital for over 20 years, specializing in the care of the older person in her early career, then becoming a clinical nurse specialist in stroke in 2012, and then more recently an advanced nurse practitioner in stroke care with a main focus on acute stroke care. So Trish, can I hand over to you? And I know you're going to talk to us a little bit about stroke prevention and managing those risks that Niamh has outlined already.
Thank you, Neil, very much, and good evening to everybody. I'm going to address on and expand on some of the risk factors that Niamh mentioned there in the stroke. And I suppose this is looking at each individual to look at their own risk factors and maybe assess how these risk factors pertain to them and their health. And if by knowing your risk factors and understanding what your risk factors are, you'll take that one step closer to hopefully trying to prevent a stroke, because as Dr. Hannon said, stroke is generally a preventable disease. So when we look at risk factors, we sort of divide them into two areas. Ones which are non-modifiable, they're the ones that we can't do anything about. And then we have modifiable risk factors. So I'll take each of those individually and I'll work through them. So the non-modifiable ones are our age, our gender, our family history, and our genetic makeup. So for age and stroke, as Neil said in the introduction, stroke can affect anyone of any age. Historically, it used to be looked at something that affected old people, but believe me, I see people in their 20s, 30s, 40s, all the way up to their 90s having stroke. So it is something that can hit you at any time. So to be aware that it's not just older people that get stroke. So with age, it's more common for men under the age of 50 to have a stroke at a younger age. But then once women pass through the menopause, we go on to pass out men in the risk of stroke. They think it's due to the hormonal protective role that hormones play for women premenopausal that protects women from the risk of stroke. But once we go through menopause, that protective factor disappears. So we go on to pass out men for our risk of stroke. So that probably takes gender and age into one. So it's more common for younger men under the age of 50, but once women enter into their 50th decade or their 5th decade of life, their risk of stroke goes on to pass out men. Your family history is something too that also does play a role in stroke. It goes to your parents. So if your parents had a stroke at a younger age, you have a slightly more risk of having a stroke as well. So if a father had a stroke at a younger age, or for women in their 50s, you will have a slightly higher risk of maybe having a stroke yourself. And genetic factors are ones that we look for in younger people, really, as more of the rarer causes of stroke. So some of the diseases that you may hear of in the past, or you may know some people that have these genetic disorders, they include CADASIL and amyloid angiopathy, Marfan syndrome, and sickle cell disease. So these are rare causes of stroke, but they are there. So there is a genetic component to developing stroke. So they are the ones that there's not a whole lot that we can do about. So then when we look at the risk factors that we can alter and we can take control over, the modifiable risk factors, we break them further down into medical and lifestyle. Even though we break them down into both medical and lifestyle, they are interchangeable. So for instance, if you have high blood pressure and you're on blood pressure medication to try and control that, but if you continue to smoke and leave a sedentary lifestyle, you're not really making the lifestyle interventions. You're sort of relying on your medication to lower your blood pressure, when you're actually probably for every cigarette that you're smoking, you're undoing the benefits of your medication. So it's about going hand in hand with the medical intervention and lifestyle. So the medical risk factors for stroke, and Dr. Hannon has already mentioned some of them. The first one is high blood pressure. Then we have diabetes, high cholesterol, atrial fibrillation, and disease of the carotid arteries, which is the blood vessels that run up the side of your neck. So high blood pressure or hypertension is probably one of the biggest risk factors for stroke. And what high blood pressure does is it hardens and it speeds up the rate at which our blood vessels in our body harden. And it can also cause problems to our kidneys and to our heart as well. So having high blood pressure is something that needs to be looked at probably from our 40s is when our vessels start to age. So it is something that builds up over time. So it is important for you to keep an eye on your blood pressure and to know the numbers. So I would often meet people and when in the hospital and going through risk factors with them, and you'd ask them, well, do you have high blood pressure? And they go, oh, I do. And I say, so what's your control like? What are your numbers? I have no idea. People don't know what their blood pressure is doing. They may be taking their tablets, but do they know that their tablets are actually working for them? So it's very important to be aware of what your numbers are doing. High cholesterol is another area which gives rise to stroke, and cholesterol is a substance that we require for the body, and we need it in our body. And it's usually produced by the liver. And it's required for repairing our cells, and it's required for the production of some hormones. So as I said, the liver produces its own level of cholesterol that's required for the body. But by eating and taking in bad cholesterol, bad fats, saturated fats, hydrogenated fats, and to give you an example, I suppose what they'd say is that something that's solid, so an oil or a fat that's solid at room temperature would be a high saturated fat. So in our diet, and especially in our Western diet, we consume a lot of these fats. And that is stored in the body as bad cholesterol, or your LDL. So that's the figure that we look at. So when you get a blood cholesterol level checked, you usually get it fasting. So you know the total cholesterol level, and that we like that to be less than 5, but you also need to know what your LDL is, and that's the bad. So that's the cholesterol that gets stored, that sets up inflammation in our blood vessels, that causes plaque, that causes buildup and blockages in our vessels. And we like that number to be less than 3 in a person that's never had an event. So a healthy level of LDL would be 3 or less. And it's also important to know what your HDL is. That's your happy, your good cholesterol, because your good cholesterol can negate the bad cholesterol, and it can try and slow down the inflammation that the LDL produces in our body. So knowing what your cholesterol is very important, and following a diet that's well balanced, low in saturated fats. I'll go on to talk about prevention in a minute. So your cholesterol is very important. And I'll tie in carotid disease with that. So what in stroke, what can happen is when that buildup of cholesterol and plaque happens, it can cause a narrowing in the vessels in our body. And especially running up the side of our neck here, we have the carotid artery. And if that vessel gets very tight and blocked, the blood flow going up to the brain can get impeded. And when blood flows down or slows down in the body, it tends to form a clot. So a clot can form at the site of the plaque or at the site of the blockage, and can go up to the brain and cause a stroke. Or what can also happen is that plaque can erupt, or it can break up, and that can travel up to the body. The cholesterol plaques will travel in the blood and go up and cause that blockage and cause your symptoms of stroke. So that's how carotid disease, so that buildup of plaque, of atherosclerosis is the big fancy term for it, can cause a blockage in the blood supply going up to the brain. Atrial fibrillation is one that can cause stroke as well. And atrial fibrillation is an irregular heartbeat. And with atrial fibrillation, it can be an irregularity in the heartbeat that can be persistently there, or it can come and go. I did notice one question there earlier on that's saying, how can you have it one day and not be detected? So atrial fibrillation is not always there. It can be something that we have to chase and look for. But with atrial fibrillation, it's an irregular heartbeat, which causes blood flow to stagnate as it goes through the heart. And again, as I said, when the blood flow slows down in anywhere in the body, its automatic response is to form a clot. And then that clot can get out into the system, travel up through the heart and up to the brain to cause your stroke. Diabetes, again, is a condition where you can't control your blood sugar. And diabetes can tend to speed up the rate at which our blood vessels harden. It can cause damage to the blood vessels as well, which can in turn lead to high blood pressure and to kidney disease and heart disease and stroke. So diabetes is very important, that even if you are pre-diabetic or type 2 diabetic, to try and control your diet and exercise to improve your outcome and to try and reduce your diabetic risk. So they are the main medical risk factors. And then I'll just touch on the lifestyle. So your lifestyle, we've already mentioned smoking. So smoking increases your risk factor for stroke enormously. So if you continue to stroke and to smoke, if you have diabetes, if you have hypertension, adding cigarettes into it is just really increasing that risk greatly. So our advice would be, if you can at all, try and give up the smoking. Diet is a huge component. So eating a healthy diet is very important. Again, try and become familiar with what's healthy. We do promote sort of a Mediterranean lifestyle, so lots of fresh vegetables, fruit, drinking water, staying away from red meat, eating whole grain, pulses, nuts, all the stuff that we tend not to like is probably what's better for us. Trying to stay away from the processed, refined, anything that's too white, so your white breads, white rice, pastas, anything that's processed is not good for us. It speeds up the level of LDL. It helps us to store fat. It gives us sugar highs. It promotes our body to hold on to fat and to sugars longer. So you need these, what they call like fast burning glycemic foods, are not good. Our BMI, so our knowing our weight and obesity is a huge risk factor for stroke. So if you should try to understand how to calculate your BMI, and it's something that can be done quite easily through lots of apps online, or your doctor or nurse in your GP practice would be able to help you to calculate that. So obesity, again, sort of goes hand in hand with your sedentary lifestyle. So if you're not physically active, and if you're not exercising regularly, these can all feed into your medical risk factors. So to go back to reiterate, if you've got two medical risk factors, so if you've got diabetes and high blood pressure, and if you look at your lifestyle, if you are overweight, if you're not doing enough physical exercise, if your diet is not well balanced and a healthy lifestyle, you are increasing your risk fold for having a stroke even greater by not controlling lifestyle intervention. And sometimes we don't always jump in with medication to help control your blood pressure. We do promote people to try diet, to try exercise, to try and adopt a healthier lifestyle, because that may even allow you to reduce the dose of medication if you're already on, or may even prevent you needing to start medication in the first place. So having a well-balanced, healthy outlook to your lifestyle is very important as well. And another one that can slip under the radar for lifestyle is stress. And we've seen a lot of different type of stresses, I suppose, over the last 10 months with COVID, where people have a lot of stress, and people are finding themselves out of work, they're finding themselves isolated. There's a huge fear factor around COVID, and that can lead, again, feed into diet not being great. It can lead into increased alcohol consumption. It can lead into smoking. We're not getting out and about exercising as much. So again, stress, we tend to try and control our stress by being by being good to ourselves in maybe not such a healthy way. So stress, our lifestyle, what we do, it's quite important to reflect in looking at us and in looking at yourself, to do an assessment on yourself to see where could you be doing things a little bit better in relation to your lifestyle. Certainly if you do have any of the medical risk factors for stroke. So what's important, and maybe it's a simple way to say it, is to try and know the numbers. So what I mean by knowing the numbers is knowing what your blood pressure numbers are. So we try to aim for a healthy blood pressure of less than 130/80. Now, this is not for everyone. This is a generalizable figure, because if people have different competing health issues. So for diabetics, the numbers might be a little bit different. If you're older and if you're at risk of falling, we may not want your blood pressure to be quite that low. So these are generalizable numbers. So for the general population, we like blood pressure to be less than 130/80. So when you go to your doctor, when you go to your GP or your practice nurse and they take your blood pressure, ask them what the numbers are. Know what your cholesterol is. Know what your total cholesterol is. Know what your bad LDL cholesterol is, and know what your good HDL cholesterol level is. So know that number. Know your BMI. Know that number. So a healthy BMI should be between 18 and 25. So calculate your BMI for your stature, for your height, and get to know that number. And if you go to your GP and you get blood tests done every year, if they do a glucose or look for diabetes, get to know that number. So know your numbers and what they mean for you as an individual. So that's very, very important, that people start to take a little bit of ownership over their own health. So get to know your numbers, get to write them down, get familiar with what they mean for you, and then look at your lifestyle and look at how maybe we can do things a little bit better. And can we exercise? Are we exercising enough? You know, they say out of the week, and I looked this up last night, so there's over 100,000 minutes in a week. And what we should be trying to aim for is exercise of 150 minutes. So try and get to know, get healthy, and reduce your risk of having a stroke. Thank you.
Thank you very much, Trish. Covered a lot of ground there, a lot of great information. And I know some of that, we'll come back to some of that in the questions that are already coming in. And actually there is, just as appropriate to mention at this point, that there is a message in here to tell all participants that we have just launched Quit Smoking West, a free stop smoking service for people in Galway, Mayo and Roscommon. A stop smoking advisor helps clients to put a plan into action and supports them throughout their stop smoking journey with weekly sessions on telephone, mobile, online, whichever method suits. So just call the HSE Health Promotion Office on 091 737262, and that's thanks to Adrian Lyman. Thank you very much for that. It's very relevant. So we've got the medical perspective on what is a stroke, very clearly outlined to us. And Trish has talked to us about the risk factors for stroke, some of which we can control, some of which are outside of our control. And another very important element, of course, of the stroke journey is the recovery. And in that regard, one of the health team members that plays a very significant role in that is occupational therapy. And our next speaker is Kyra Breen. This time we're going to Donegal for her a native of Donegal, now living in Galway, and she tells us that she's missing the hills, mainly in these times of limited travel. She came to Galway in 2005, but by a circuitous route, Dublin, Sydney, and the outback of Australia, where, as well as gaining valuable experience as an occupational therapist, her favorite work was using the home visit jeep to chase kangaroos off the runway so the flying doctors could take off. Very exciting. Must be very boring to be back in Ireland against that. But stroke is a topic close to Kyra's heart, as it has affected her own family. And she has spent most of her career of over 20 years working in the area, either directly or indirectly, including at national level. So Kyra, you're very welcome. And maybe you might just start by telling us a little bit about occupational therapy and how you help in the process of recovery.
Thank you so much, Neil, and thanks everyone at Croí for giving us the opportunity to talk this evening. And what I will be talking about is coping with changes in daily living after stroke. And this is really heart and soul of what occupational therapists are all about. In fact, World Stroke Day also shares its anniversary every year with World OT Day, which I always think is a great coincidence. And certainly for myself, who has a deep interest in both areas, it's makes for a busy week, but a very enjoyable week, connecting with people to share, I suppose, a little bit about hopefully how we can help people who are on that journey of recovery. And really, recovery is all about change, And I think, you know, more than anything else this year has been an exceptional year, as Trish touched on there. We're really living through the most unprecedented of times, and it's especially change that we didn't choose. I'm sorry now, just one moment, my slides are not moving on here. I'm sorry, my slides are not moving on here. Oh, there we are. Okay, so my apologies. We're living through unprecedented change all across the world at the moment. It has caused, COVID-19 has caused this enormous change in all of the world, disrupting our lives, our habits, our culture, our way of living, and, you know, change that we didn't wish for, change that is unwelcome, is the most difficult change to deal with. And similarly, stroke is a sudden change, a bolt from the blue for many. And many on this line right now may be contending with the aftermath of stroke, or indeed may love somebody or be caring for somebody who is contending with the aftermath of stroke and recovery. So what do we look at as part of the rehabilitation journey? So I suppose what we're thinking about is that treatment for stroke is improving constantly. Very, very welcome improvements that Niamh and Trish have touched on there, including both immediate interventions. They're, I suppose, the big headline grabbers, but also in the field of rehabilitation as well. We're learning more and more every year about the improvements that we can make as therapists, and for people themselves, what strategies they can adopt and bring into their daily life that can actually make a big impact in terms of living with stroke. Unfortunately, even at 3 months, over 80% of patients may still have some symptoms, and some may have this to such a degree that it impacts their daily living. For many, this can be mild or subtle symptoms, and perhaps you wouldn't even know to look at the person. There might be subtle fatigue issues, maybe subtle language problems, but this can go right through to people who have, unfortunately, very much more severe impairments and may need help for all of their activities of daily living. So stroke can cause a whole range of symptoms depending on where in the brain the stroke has occurred. And that may include physical issues, visual, swallowing, or problems even with your thinking skills, such as your memory and concentration. And as well as your ability to do your tasks, your satisfaction with those tasks may also be affected. So while perhaps you can have a shower and get yourself dressed in the morning, you may feel so fatigued at the end of it that actually your satisfaction with that is very much diminished. And those quality of life issues and balancing acts are things that are also important to consider after a stroke. So what can influence recovery? I'm talking here, I suppose, about after the immediate interventions that the thrombolysis and thrombectomy. So what other factors can influence recovery? Big one for any one to be thinking about in terms of the profile of what type of impairments or difficulties somebody might have is where in the brain the stroke has happened. Different parts of the brain have different functions, and we know that. And naturally, if there's a stroke causing a blockage or a bleed in a particular area of the brain, the functions of that area and also the pathways that travel through the area may all be disrupted and affected. The size of the stroke, so in other words, how big that blockage was, how much of the brain tissue was involved, or indeed how quickly you were able to access treatment, can also impact on that as well. Of course, recovery is also affected if you're dealing with other medical factors or other disabilities, and those can interact to make recovery more challenging, of course, and may impact on your ability to manage the intensity of rehabilitation that might deliver the best results, or may mean that techniques need to be adapted and compensated for. Your memory and ability to learn new things. Rehabilitation is all about memory, and while the majority of what we work on are very familiar daily tasks, you might be asked to do them in ways that are kind of a bit different and very unusually for you. So trying to figure out how to tie your shoelaces with one hand, or even, how to wash your hands one-handed. It's a very topical one at the moment with COVID-19. So very different methods and different ways of doing even familiar tasks. Goals and motivation are really, really important. And I'm going to come back to that a little bit later on. But, stroke can be such an overwhelming situation, and it can really result in a lot of challenges for people in terms of staying motivated. It can be a long road, and, there can be a lot of bumps in that road. And one of the things that really brings people back on that road and back to where they need to get to again is having goals and having a focus. That can be a really specific niche thing to you, that, your particular barometer or your particular thing that is your kind of light at the end of the tunnel. Or it can mean even the small thing. What goal am I going to set today? Okay, so today I'm going to try and get out for that walk because I know my exercise is so important. Or today I'm going to try and have a phone call with one of the family, despite the fact of my communication problems or whatever. So those are things that certainly really help people on that pathway. Access to suitable services is really important, including rehabilitation, including the support end of things as well. And finally, your environment. So is your environment a supportive environment? Is it helping you to, recover? Or is it a barrier? Is it causing, is it stopping you from being your best self in terms of that way? In terms of rehabilitation, the brain has a certain amount of, certain ability to reorganize itself. And then we can further modify the function using a range of rehabilitation techniques, or indeed compensate things within tasks to address the specific problems that somebody may be having. The links between different areas of the brain are often called a pathway. And really, rehabilitation is all about helping people to walk those pathways again and again and again. And the more you walk a pathway, if you're even thinking about making a pathway through a forest, if you walk it once, probably if you come back tomorrow, everything will have sprung back and you won't be able to find it again. But if you walk it and walk it and walk it and walk it and walk that pathway, practicing the task, the stronger that pathway becomes and the more likely you are to retain that skill. So in therapy, we're all about intensity and really about trying to make sure that you get the right dosage, as it were, of the therapy that you need to recover as well. These are things that certainly, if you yourself have had a stroke, or if your family are looking to assist you, helping you do those repetitions and really having patience with yourself is half the battle, to kind of do what may seem like a repetitive task again and again, but it really is, the brain science is there behind it to say this is what we need to do, and unfortunately there's no magic wands that can shortcut that significantly. Physical changes that we can expect would be issues in terms of weakness, balance, hand function, coordination, changes in sensation. Usually affects one side of the body, and also, we think about, I suppose, it affecting arms, legs, faces even, but it can affect things like the muscles that you use to go to the toilet, or the muscles that you use to swallow your food. Difficulty with thinking skills are another very common one, and these can range from very subtle difficulties with multitasking right through to profound difficulties in terms of problem solving, or in terms of being able to manage daily tasks like banking or working. These are areas that we work a lot on with people, and sometimes it can take a while for some of these issues to emerge. The focus can often be very understandably on maybe the arm or the leg in the initial phases. And sometimes, particularly with subtle issues, it may only be after you go home that you realize the real impact in terms of some of those thinking skills. Perceptual difficulties are another one that's probably possibly a surprise to many, and this can impact you because it can reduce your awareness, believe it or not, of one side of your body or one side of your environment. And that's often accompanied by a weakness, although it's not always the case. And it can also be affected by the eyesight in half of your visual field of each eye as well. So these are, you know, things that people are certainly not expecting when they think about having a stroke. And it can be quite a bewildering time for people in those very initial stages. And indeed, after going home and navigating, perhaps the hospital is in many ways a protective setting. And I also think that the transition to home is a critical milestone, or the transition indeed onto care somewhere else, maybe in somebody else's home or in a residential facility. It's a huge time when really the dust has settled in many respects, and the true issues kind of begin to emerge. Emotional adjustment is massive. With regards to stroke, it can affect certainly a person's personality, or it can affect, you know, their emotional maybe ability to regulate some of the emotions. But no matter where in the brain it has been affected, the impact of having had a stroke is in itself requires a huge emotional adjustment. And this is a journey that people are on for many weeks, months, and years after a stroke. I think it's one of the things why places like Croí, places like other support groups, even Facebook groups, online supports are so important, because this is a thing that can kind of sneak up and bite you at various different points. It's one of those things that kind of you can be doing fine one moment, and then perhaps something like a trigger of you know, another illness, or a trigger of even recent events, or a transition like retirement can really come and knock you for six. And sometimes that emotional resilience is something that can be impacted on. Many people will be aware that stroke can also impact communication, can impact your ability to understand language, and also your ability to generate speech and language that's meaningful as well. This is a particularly, I always think this is a really challenging one, and a really cruel one in many respects, because at a time when we need to connect and express how we feel about this awful thing that's happened, we've lost the means to do that. And certainly it's a source of much frustration for many people. And it's a real challenge for families trying to interact and trying to learn new strategies. So can't stress how important it is to, again, use any resources that you can find to really link in with your speech therapy colleagues or other colleagues that might be working with you, and really look at some strategies that can try and help you. Again, there's a lot of online resources. They're not for everybody, but certainly a lot of information out there. And again, it's an area that can recover, and all of these areas are areas where there is improvement over time as well. So returning to daily activities, it can seem really daunting to face new challenges, and you may need support at various intervals. It can become really important to prioritize and plan ahead more, so that you can focus your energies on what's important and meaningful to you. And I've mentioned some of them there: self-care, home, work, driving, relationships and intimacy, or dealing with, you know, even things like grief and loss as well. Transitions and changes in general, and this has nothing to do with stroke, but in general, even transitions and changes that we want, like buying a new house or having a new baby, or you know, getting a new job, even those we really want and long for, can be really stressful. And especially, as I said, with stroke, something you didn't wish upon yourself, that's for sure, can be incredibly stressful for you and indeed for those around you. The reality may confront when you're outside the protective bubble of the hospital. And I think particularly at the moment with COVID-19, your people, whoever they are, may not have seen you and may not have had that time with you to really realize the journey that you've been going through. And indeed the opposite way as well, that you may not have realized what they've been feeling at the other end of the phone or the other end of the tablet. And you may all feel on an emotional roller coaster for some time. That would be incredibly normal under any circumstances, and particularly in current times. But there can be pros and cons to our new way of living. Sometimes people may be at home more, people can have more company or more access to the people around them if they're living with them. But this can also mean homes can be noisier and busier if there's people working from home, if there's more children that are at home more rather than playing outside, and various things like that. So Every cloud has a silver lining, but sometimes it rains. So tips to help in terms of discharge planning. I thought, you know, some things that could really help at the moment would be particularly video or phone calls. Even if communication is difficult, it can be sometimes just a relief to see somebody's face. And certainly the stroke units and the therapists, the nurses, the teams, they're all very open to doing things in different ways. We've all had to do things in different ways. And I think these are really important things that we can offer to people. Family meetings, perhaps, with the treating team can be useful to make plans, particularly because you may know less and less of what to expect. Sometimes people would have been able to go home for hours out, or would have been able to go out for a weekend to test things out before they come in. We can't do that, unfortunately, anymore. And it's a real loss to us as a rehab team, but certainly it's an even bigger loss to families and people with stroke who are planning for home. If you're not big into meetings, or some people may find them a bit overwhelming, you know, maybe a one-to-one, maybe there's a staff member you have a particular rapport with, and giving them a chat, giving them a call. People really, really want to, I think, help and support people. And honestly, I can assure you that the Galway stroke team in particular, and I know there's people from all over the country, you know, we really want to help, and we really want to prepare people as best as we can. Prepare in advance any questions that you want answered, and you may need to prepare your home as well, particularly if there are physical or cognitive issues, and maybe seek advice from an occupational therapist, or indeed, you know, you may know a local public health nurse who knows you and your family well as well. They can be great resources also. Find out what follow-up is going to be arranged, and are there exercises or techniques that are helpful to continue, and what supports are out there for you. You know, nobody should have to navigate this alone, and there are lots and lots of supports out there, and certainly, but if you've never been in this situation before, they can be hard to find. So certainly finding those things out are really good questions to ask. A lot of follow-up consultations and a lot of follow-up rehab sessions might be done via virtual means. So particularly with virtual medicine or with tele-rehab, prepare any questions in advance. Prepare a quiet space. Have somebody with you, perhaps, if you need some assistance with logging on to the platforms and the various different technologies that you may need to use. Sometimes a second person can tune into that consultation, even if they're not the patient. So with your consult, but that needs to be set up in advance, so that the particular clinician can remember to bring two people from the waiting room. So perhaps if you're living in Galway and you've got a daughter living in Sligo, there may be an opportunity to have somebody else there, but definitely set that up in advance if you can. Again, people are usually very, very happy to facilitate. You may get a practice session to test it out, and make sure you have things like your hospital number, your date of birth, those type of things on hand, because you may be asked for them as part of your log on. So kind of coming towards the end, coping with change, there's no magic formula or right way to cope with change, but certainly things that can help are developing a routine and a consistency, a predictability to the day, if you like. Goals that I touched on earlier, and having a sense of purpose. Maybe you're not going to reach your final destination goal today, but maybe there's a small step you could take towards that. And that's really what's important to consider. Maybe you can connect with nature, or maybe consider things like, you know, practicing gratitude, meditation, faith, things that are supportive and helpful to you. Use trusted sources of information if you can. And most importantly, I think self-compassion is key. This is probably not your first rodeo. Many people have been through terrible times before. Maybe you've been through another illness. Maybe you've lost somebody. Maybe you've lost your job. You know, there can be a lot of resilience in us that we don't know is there until we go looking for it. So I really think draw on your strengths, and they're individual to you. Think about how you've coped before, and be kind. Thanks.
Thank you, Ciara, and some very practical tips and advice there. Really appreciate that. Now moving on to our final speaker, and it's well known that there is no greater experience than the lived experience. And as we indicated earlier, fortunately, not all strokes are devastating, and many people do have very mild or limited disability as a consequence of a stroke. And our next speaker, Norita ní Chartúr, is one such person, a Connemara native from Camas in Connemara, a Gaeilgeoir, and she works as a communications executive with NUIG, where she teaches radio journalism and broadcasting skills. Norita suffered a very serious cardioembolic stroke. So if you remember, there were two types of stroke, the clot and the bleed. So this was the clot type stroke in September 2018. So just about a year ago, where a clot traveled from her heart to her brain, lodged in the main trunk of her brain. And she credits her being alive today to the quick thinking and presence of mind of her dear friend who was with her when she had her stroke. So she's going to tell us her story, and very interesting feature actually of her story in today's Galway Advertiser. And if you're not from Galway, you can get the e-version of that, galwayadvertiser.com, I think it's their .ie. Norita, you're very welcome, and thank you so much for agreeing to share your story.
Thank you, Neil. How are you? Good evening. Gomani Dire Berfad. As you said, yes, it did happen to me, and I never thought it would, but it did. It was a stroke of luck that I was where I was. There was a power cut at my workplace in Croi. NUIG has a base out there, and I was teaching out there. My friend had this idea that we do some retail therapy, and I was always good for retail therapy. Neither of us can remember where the stroke occurred, but it was about a quarter of an hour outside Galway City. It was very sudden, no warning, not that I can remember. I had a sneaky fag in her car, and all of a sudden I watched it drop out of my hand, and I was more concerned at the time about burning the lovely carpet in our new car than I was about the cigarette, but it registered very quickly, oh my God, something has happened here. But I had felt very tired that day and maybe the previous couple of days when I look back in hindsight. And I remember as I was speaking to Geriatric that I was very aware that I had difficulty speaking and that I was spitting. And I said, oh my God, I've got a stroke. And I did ask her, I turned and I asked her, I said, am I after getting a stroke? And she nodded very gravely and she said, yes, you have, Norita. And her main concern at the time when it was happening was, this one is going to object, knowing my determination to do things my way. She's not going to want to go to hospital. But I knew immediately. I had cared for my mother prior to that 8 years, for the last 8 years. So I knew the signs and the symptoms of stroke, and I count myself very lucky that I had read a lot of the literature, and I said the numbness in my arm was so sudden, and when I tried to pick up the cigarette I couldn't, and it was very unusual. Also the difficulty that I had with the speech and the tiredness, and I knew the only way was the hospital, and that was the best place for me. She drove calmly, she didn't ring a single person on her mobile, and it must have been very traumatizing for Geriatric. When I think back on it, and I didn't initially at the time, but it must have been desperate looking at me. My face had contorted. I didn't look in the mirror because I didn't want to look in the mirror, but she said that you could see clearly that I had the signs that you would associate with the onset of stroke. She drove calmly and quickly to NUIG and into the hospital, to, as I call the old regional there, and said, stay in the car, Norita, while I get somebody to help us. And she did. She went over to the security officers who were there outside the door, and they were immediately at the car. And I remember that, thinking that she had parked so far away, but of course my sight was beginning to be affected by the clot in the brain as well. By the time that Geriatric parked the car, they had done the scan in NUIG. That's how quickly the team moved in the hospital. I couldn't believe it when I look back on it. The way they treated me, the care that I received, I was very, very lucky. And I was very one of the lucky ones that I was where I was at the time, a very short distance from help and from hospital. And it wouldn't happen to everybody, and it doesn't happen to everybody. But that was my luck on the day that that's what happened. When I was in there, I met a team of people. I can't remember a single person that I met, but the one person who stays in my mind, who will stay with me forever, is another guardian angel, is consultant Michelle Canavan, who works in the stroke ward. And I remember her comments. At no stage did she frighten me. Did she tell me? I don't ever remember that they spoke to me about having a stroke, but they said, you have to go to Dublin, Norita, and you are going to Dublin. And that was, I took it that was the best place for me to go. and I didn't object. I certainly wasn't in any position to object. They had given me the medication for the thrombolization, because I'd asked Michelle that, and I hope I'm quoting her correctly. It didn't work because of where the clot was in the main trunk of the brain. So they said, we're going to send you to send me to Beaumont in Dublin. And I remember the speed of the ambulance and the way they moved. And it was a guy and a girl. And I remember lying there thinking, oh my God, I am on this journey and I'm on my own. But it was over in a matter of seconds. Now that's ridiculous because it wasn't, but that was my recollection when I look back on it. I don't remember that I was waiting that very long. And I was met in Dublin, in Beaumont, by Dr. John Thornton and his team there. And again, I was so lucky. He performed the thrombectomy, which was the removal of the clot by suction, as previously mentioned. And he is an expert in this field, and he told me during my very short brief time there that he performed something like 220 of these thrombectomies a year on patients from the west of Ireland. We didn't get into the nitty-gritty details, but I remember thinking at the time, I had my journalist hat on, those numbers are very high, and that's serious. And imagine that if you live that far away in another part of the country trying to get to this hospital where you need that desperate help that you needed so desperately. But he did what good doctors do. He did it very well, very successfully. The procedure was uncomfortable, I'll be honest. It wasn't very nice to have to go through, but I got through it and I came through it. And I remember that he had called my husband, who was on his way home. He was a farmer and he couldn't pull into the hospital. And anyways, they were going to send me off. They weren't going to wait for him because time was of the essence. He asked him, will she make it, doctor? And he said, if I get her in time, he said 50% she does and 50% she doesn't. Those were the odds that I faced that particular day, and the sudden speed of that stroke that I suffered on the 20th of September 2018. But again, I was very, very lucky and very fortunate that I met that man. And I believe the clot traveled from my heart to my brain, but I believe now that the clot that I suffered, that it worked, the thrombectomy worked very well for the removal of that clot, trying to put it in a simple term as I can. So again, I suppose I was very lucky in that respect. It doesn't always work out that is the case. And it was, I think, once in up through the groin that the clot was subtracted, and that was it. My immediate reaction was to lift my left leg in the air, and everybody started laughing. And I remember the consultant saying, will you lift that leg again, Norita? And I did, and he said, she's back. And it was so instantaneous. The removal of that clot brought back all the damage. Well, it just restored the damage that was being done. My left side was gone, my left leg, my left arm, my speech was impaired, my swallowing was beginning to go. My vision, as I had said, I knew there was something, everything seemed so far away and so distorted. So by the procedure that he did on that fateful afternoon, he restored me as I am, and as you see me here tonight talking to you. For that, I'll be eternally grateful, and grateful to the hospital in Galway who moved so quickly and who just took the time to look after me. I felt I was a priority and that I was in serious need of help, and that was the help that I got. I came back to Galway. I spent a night in Dublin, and again, they looked after me very well. They sent me back to the stroke ward, where I was again admitted under the care of Michelle Canavan, and that was the part of it that I loved. I went back into the original consultant I had met and who had sent me to Dublin. That was Michelle, and I have stayed with Michelle, and I have seen her for all of my meetings ever since, which I found to be of great benefit to me because there was continuity in my care. She understood my case, where I came from, and exactly what I needed. And she was always there, even at the end of an email when I needed her. And for that, I'd like to congratulate them and for the wonderful work that they do. My recovery was very good because of the immediate relief that I had got from the removal of that clot from the brain. My walking for a time was affected, and I know now when I look back on it, I had a tear in my glute, and that created a lot of problems. But when I look back, and when I'm being totally honest with myself, the problems with the left leg and the walking and my gait, so to speak, it was to do with the stroke. But I worked very hard on that. Exercise was a priority for me. and I got out. I don't get out as much as I'd like to, and I don't do as much exercise as I'd like to, but I do make an effort. I gave up the cigarettes. I was a smoker. I wasn't a heavy smoker, but all the same, I was a smoker. Weight is still an issue and will be. It's my long running battle, but someday I'll win that battle too, and I'll emerge as a skinny millink somewhere in the world. What else can I say? To stay positive. It's very, very important not to be overwhelmed. And it's easy to be overwhelmed. And it was easier for me because I think that I came away so lucky in so many respects. So it's easy for me maybe to be smiley and to be happy. But I did have my dark days and my dark moments. But I just had one quote in my head all the time: get busy living or get busy dying. And I chose to live, and I appreciate life. And I look out the window every day. It doesn't matter if it's raining from the heavens. And I say, thank God I am alive. And there were people there to help me on the journey, from the doctors, the consultants, people I met, physiotherapists, even in the hospital in Galway. They were very, very good to me. And they gave me time, they gave me space. And I still deal with it. I still find it's very important to talk about stroke. I don't hide away what happened to me. And I know, to be honest, that people were appalled when they heard that I had a stroke. And even today, it's happened again today. The reaction is always the same. Oh my God, you're so young. But sure, why not me? That's the way I looked at it. But it's important to tell the facts as they happened. It's important to tell. Sometimes you'll get tired, sometimes you'll get down, but you just get up and you keep on fighting. And there are people there that it's important to talk to and to share. To be honest, there are days you'll get very, very tired. I was one of the lucky ones in that respect as well. I didn't really suffer from chronic fatigue, but I did take time out the first time in many a year. In the first month, the initial month after I came home from hospital, that I went to bed earlier than I had ever gone in my life, and I stopped staying up late. And I think that, when I look back in hindsight, was a great help to me. But it was a very difficult thing to do. I had to force myself to do that, to sit up, to slow down, and to forget everything else. There was nothing more important in my life than my health. And you kind of get carried away with work and with other responsibilities. But when this happened, it forced me to revalue, to refocus. What was important to me was my health and my family, and nothing else matters at the end of the day. So that took quite a while to adjust to, and I'm still adjusting, to be honest. But that's life. Other people have suffered a lot more. But to be aware and to move as fast as you can when you see somebody like me or in a particular situation, that you should know the signs of the stroke. So thank you for listening. If you have any questions.
Thank you very much, Norita. Clearly, you've put an extremely positive spin on something that was obviously and is very traumatic. And I really like your message there. Get busy living. So we have some time on our hands now. I'm going to invite back our speakers, and we have a very large number of questions. So I'm going to suggest that we try and get through them, as many of them as quickly as possible, to try and answer as many as we can. Maybe if I start with you, Niamh, if that's possible. The thrombectomy, clearly, Norita is almost like a textbook case of best practice in early identification, in quickly, quick CT scan, diagnosis, Dublin thrombectomy. Is that normal? What's the success rate like? Any comments on that?
Yes, we aim for it to be normal. I think, thankfully, Norita had a very successful pathway. We operate very quickly, and actually it's interesting to hear Norita saying that she felt the team were very calm, because we are running around like lunatics trying to get everything done as quickly as possible. And I often find myself reassuring the patients, look, it looks like I'm running around, you're not in any danger, I just want this to move as quickly as possible. We have a national audit that happens to keep track of all of our time. So each step of the process is monitored and compared to a national baseline. And we do very well in Galway in terms of our time to get the patient through the doors of the emergency department onto a CT scanner, scan done, scan resulted by our radiology colleagues, and a very quick decision then to get them on the road to Dublin. So it does run well. Unfortunately, there's nothing we can do about our geographical location, which is, even on a blue lighted ambulance, about an hour and a half from Dublin. We've tried running helicopters as well, but actually it doesn't take much time off that process. So that is probably the biggest limitation in terms of thrombectomy. While the patient is in the ambulance getting up to Dublin, unfortunately, it is possible that further damage is happening to their brain. But I would say that our network of colleagues, it starts with paramedics all the way through our emergency department colleagues, radiology, and then our colleagues like Dr. Thornton in Beaumont. We just have a really good network. Everyone has the patient at the center of what they do. And we're constantly trying to improve our timings, constantly trying to improve that pathway. We're always aspiring to do better.
Yeah, and just on that, I mean, and even in the questions here, there are a number of questions around people for whom the thrombectomy wasn't a success. Talk to us a little bit about, like, even the percentage of success, how many of them are or aren't successful, just in terms of setting a realistic expectation of what can be achieved.
Absolutely. So unfortunately, even patients who present within that time window that we can intervene, not all of those patients will be suitable for thrombectomy. It depends on where the clot is. As Norita said, her clot was right in the main trunk, so that's actually quite easy to get to. If the clot is further out, if the clot has been there too long and it's almost taken root, if it's in a point that the technician in Beaumont can't actually get to it without causing more damage to the person's brain, those are the type of cases where thrombectomy will unfortunately not be helpful. The main message really is the quicker that we get this person to Beaumont, the better the outcome will be. But in terms of all of the strokes presenting to us, and in Galway region, we're looking at probably 350 in the next 12 months coming through our doors in Galway University hospitals, that only about 10% of those patients will actually be eligible for a successful thrombectomy.
Okay, that's good to know that get some realistic expectation. Kyra, if I just jumping the number of questions in for you, do you have any tips on helping with memory? Are there any games or apps that you'd recommend in the recovery process?
Yeah, memory is a big one. It often comes up actually. I suppose there are lots of different apps out there, but probably the evidence would suggest the best thing is actually compensatory strategies and making them habitual. So that could be, and certainly something that's online. A lot of us have smartphones now, online reminders. But it can be simple as, a calendar in the back of the kitchen door as well, So I think really what the big thing with strategies is not just doing it, using it and forgetting about it, but actually making them a part and parcel of your daily routine and factoring those into how you plan your day, how you go to the shops, how you plan ahead, for daily events.
Okay. And then another one for you, if I can, clearly, the transition home is also traumatic. From an OT point of view, what supports are there available in the community, and how does one identify these? How do you get in contact with OT services?
Yeah, so the biggest service, I suppose, that one of the ones that we have in Galway, and we're very lucky to have a service, is the early supported discharge service for stroke. And that's a full team of therapists who can continue on the care with somebody in their home environment. And that really that's the ideal, for people who have ongoing rehabilitation needs. So, we would offer that to around 1 in 6, 1 in 5, 1 in 6 of our stroke patients. So that would be daily intervention, within the home environment. Outside of that, I think planning is key. And I think that's something that we've really felt to be a big factor at the moment. The fact, normally you'd have people coming in and out visiting, be it on the stroke unit or be it in the rehab unit in Merlin Park. And we really feel the loss of those contacts with people. It's very hard to convey things like that over the phone. And that's why I think, don't be afraid to be, I would say to anybody who's at home and wondering about a discharge or things like that, don't be afraid to ask for a little bit of extra time in planning that. Don't be afraid to ask for a video call to be set up, with you and your family member. And don't be afraid also, because we do it in certain circumstances, for an exceptional, discharge planning visit to happen. Obviously, we're still trying to keep footfall through the hospital to a minimum, but we can sometimes facilitate visiting for people, and particularly where there's a very clear goal like that, it may be very useful.
Thanks very much. Trish, you mentioned in the risk factors stress. One of the questions here, we loosely tend to, in common parlance, talk about stress as a, I'm very stressed, and one of the questions here is, how real is stress as a risk factor? Like, is it an actual measurable risk factor for stroke?
Yes, it is, and that's why I say it tends to be one that sort of, as you're saying, is it real? Is it not? And it's how we deal with stress. So some people, we need natural stressors in our lives. Some people say, oh, I work well under stress. I like to have a few balls up in the air at one time, and that's fine, because we need natural stresses in life to meet deadlines, to get up and do our daily activities. But it's when stress takes over, and when it starts to interfere with our well-being, when we start to manage stress with bad habits, is when it can be a factor. It can cause, so when we're stressed in a negative way, it can cause highs and peaks in our blood pressure, which is not good. As I said, sometimes people will eat more, they may smoke, they may use recreational drugs, they may drink more. So it's what that stress does to us and to our lifestyle, and how we deal with stress. Like, people can't sleep, people worry, they become anxious, so if it's a financial stress, there's job, people are losing homes, lots of worries and issues that are very real for people, and it's how we deal with it. And we're not great at putting our hand up and saying, I'm worried and I'm stressed. So it's something that people tend to deal with, and usually they tend to deal with it by something that's not healthy. I don't know if Dr. Hannon wants to comment there as well, but it's how you deal with that stress in your life.
Niamh,
absolutely.
Yeah.
I mean, Trish said it all. It's kind of the long-term consequences of holding negative stresses, and it has repercussions from your head to your toes in terms of what's going on internally. And those risk factors we've been describing, particularly blood pressure, any wear and tear on the inside of your blood vessels, is going to cause a problem in the long term.
Yeah, so that mind-body connection is real, is what you're saying very, very clearly here. Either of you, Trish or Niamh, question here: is it better to ring 999 rather than showing up at A&E, so that they bring you to the correct place? Does it make any difference in the context of signs of stroke?
Which I would say, whatever gets you there quicker. Now, obviously, we would not recommend a stroke patient to drive themselves, but if you feel you can get to the hospital safely with someone with you driving safely quicker than an ambulance arriving, it very much depends on the particular situation. If someone is very badly incapacitated with their left-sided hemiparesis, their paralysis down one side, then clearly it's a better choice to call 999. So you have to engage common sense in that sort of a scenario.
Okay, I might just throw another question at you if I can. And a lot of questions about aspirin, and obviously a lot of theories out there about daily aspirin use. So there's lots of questions and various permutations around use of aspirin, and aspirin as a preventative measure for stroke. Would you give us the sort of official position?
So aspirin, we're lucky because there's a lot of new medications that we're still a little bit in the dark about their long-term effects, but aspirin's been around for a long, long time. We have a lot of information, and particularly one of the stroke centres in Oxford has produced a lot of research along the long-term effects of aspirin. And as far as I can tell in my practice, it can only be a good thing. Now, obviously, there is proportion of patients who will suffer side effects. But in terms of someone who's suffered a stroke or is, defined by a medical person as being at high risk of having a stroke, they tend to be able to take aspirin quite successfully without any major life-threatening consequences. Sometimes people do suffer inconvenient side effects, and obviously that can be managed in a different way. But in terms of the evidence out there, the scientific evidence looking at the long-term use of aspirin, there's certainly more positives to my mind, coming from the biased position as a stroke physician. There's certainly a lot more positives than negatives for aspirin usage.
Okay. I just see one here that relates again to, just on the stress issue, a related question, jumping back to stress again. Both my parents had strokes. I've developed anxiety from this and stress. You said stress is a risk factor. Would medication for anxiety be a risk factor also?
Would medication
for anxiety be a risk factor?
I suppose, and it's very hard to give specific advice to a person, so I'll probably stick with the general overview. So does help for certain people, but again, it's trying to be mindful, and I just noted from Ciara's her last slide, be kind to yourself and be mindful. So maybe talking to people, recognizing that anxiety and working through it. Have both your parents having had a stroke at a younger, or I don't know at what age they had their stroke. I mean, it doesn't necessarily mean you're definitely going to have a stroke. And I often say to patients that I meet that have unfortunately had their stroke is, don't be worrying and spending the rest of your life waiting for another one to come by, because if we're doing our jobs right and you're doing your job right to try and prevent a stroke, you don't want to spend 10 years waiting for something that may never happen. So I would say manage your anxiety, maybe talk to somebody, try some mindfulness, try counseling, talking, and it's probably the anxiety and worry of what the stroke may have taken away from her parents and maybe taken away from her. That might be what her anxiety is, but I don't want to go into very specifics, but tease it out and see where it goes. As for medications, there are no medications out there that don't have any side effects, and one medication may be fine for somebody else and may have huge side effects for others. So I can't really generalize, talk about side effects for medications. It would be how they interact with that individual person. If that makes sense.
Appreciate that. Norita, a huge amount of congratulations and thank yous for sharing your story, describing it as inspiring and so forth. But there's a question here. Somebody wants to understand a little bit about, in your case, did you have, say, high blood pressure? Do you have any of the risk factors that were identified earlier?
I answered that question in a text, but I didn't have high blood pressure and I didn't have the usuals, but I did have atrial fibrillation. So I have had, and I've been hopping in and out of it in a regular heartbeat. And it was as a result, really, I think of that the clot formed in the heart and traveled from the heart to the brain. And I had suffered for a year previous to that. So it was, I'm sure, a huge factor in that I got a stroke. Yeah.
Okay. Thanks for that. A comment here, lots of talk about patient impact, nothing about family impact. I'm not quite sure that I'd agree with that, because I think, Kyra, you were really alluding to the wider impact. Do you want to speak to that a bit, about the impact on a family?
Yeah, I do think, and I've personal experience of stroke in a family as well, and I'm very aware of kind of how, stroke doesn't, it physically happens a person, but, the ripples, that occur across, a family, network, an extended family, or, even, I think, particularly people with younger stroke, even friends and colleagues, they kind of take a step back. Gosh, I never thought that could happen, to my friend or to whoever else. Yeah. And I think that kind of realization of our mortality in some respects is the first thing on an emotional level that can impact, So it really is impacting across the board. Of course, then there's also, for some people with stroke, physical issues or maybe caring issues that may impact on the family as well. So it may result in changed, family circumstances financially. It may result in changed, routines, and certainly different roles and responsibilities. And I think particularly in terms of, even things like, relationships and, intimacy or things like that, it can impact on dynamics in all sorts of subtle and more significant ways. So yeah, I certainly would agree with that particular commenter that there is a tremendous impact.
Yeah, and a more specific question for you, if I can. Have you used the Mirrorbox? And I don't know what the Mirrorbox is. You're going to have to tell us what it is. The Mirrorbox for people in the early stages of recovery in relation to getting movement started on the affected side, hand especially.
Yeah, the Mirrorbox is basically a kind of a little trick you play on your brain, essentially. So what you do is you set up your environment in such a way that your affected hand is placed into a box where there's a mirror, but actually what it's picking up is the mirror of your unaffected side. So it kind of tries to work on tricking the brain into thinking that there is movement in the affected side, because it can see the mirror image and the unaffected side. So it kind of goes back to that idea of pathways and stimulating the areas of the brain that are responsible for movement on the affected side. So it's usually not used as a standalone treatment. It usually is used maybe to prime the area of the brain before you would then go ahead and do some further movement or rehabilitation with the arm. But it is an effective assist, if you like, to further rehabilitation. Okay, thank you. Niamh, this is probably best for you. And again, like the last question that Trish dealt with, probably difficult because you can't get too specific, but my mother had a stroke last May. She was on blood thinners for 2 months and ended up with a bleed to the brain, which caused the stroke and left-sided weakness. And she didn't have this, no history of this before that, very healthy lady. Would you agree that the blood thinners may have caused the bleed?
That's a very common question, actually, because it is a situation that we do sometimes encounter. Obviously, blood thinners are prescribed. Personally, I can say always with very careful consideration. Most patients you're prescribing blood thinners, there will be a risk of bleeding, but you will clinically make a decision that the risk of them having a clot type illness is much greater than the risk of them bleeding. I'm very clear that there is no, the tablets themselves don't cause the bleed. So as I mentioned in my slides, when a patient has a bleed type stroke, a blood vessel ruptures for some reason, whether that's an underlying aneurysm or particular weakness of the vessel, it is not the blood thinning medication that causes the vessel to rupture. However, when that bleeding starts, obviously being on something that thins your blood will exacerbate and accelerate the bleeding. So the amount of damage that can happen in a very short space of time is certainly worsened by being on the blood thinner. But I would reassure that the person who commented, that I would hope that the person who made the decision to put their loved one on the blood thinner carefully balanced up the risks. The risk of having a clot is often a lot greater than the risk of having a bleed. Many patients will have risks for both. It's just a matter of deciding which of the risks is greater. And unfortunately, we do sometimes see people who get such complications from medications that are supposed to protect them. Okay, thank you for that. Trish, as you were talking about risks and prevention, I might address this one to you. Are there any alternative treatments or for prevention is the question, helping with things like fish oils, or do they interfere with blood thinners?
Oh, fish oils are great. Your omega-3, yeah, it's very good, and it's very good at sort of promoting your HDL and knocking down the LDL. It's very good at that. Not that I'm aware of fish oils interfering with blood thinners. Like, we used to use a lot of warfarin in the past as a high potent blood thinner, like an anticoagulant, and that used to interfere a lot with a lot of different food types. But for the more regular and up-to-date blood thinners that we use, I would not be aware of fish oils interfering with blood thinners per se. But yeah, I mean, there's lots of healthy diets and healthy that we can take. So nuts, pulses, walnuts in particular, flaxseed, lectin granules. All these things are very good at promoting the healthy oils that we need. You know, it's just trying to stay away from the bad and more of the good.
Yeah. Another question here, but I think you pretty much answered it, I would have thought, in relation to AFib. The question was, if paramedics identify AFib in ECG at call out, how is AFib not detected on a Holter event monitor in hospital? So I'm suspecting that this is an individual who had a Holter event monitor and there wasn't ECG, and then there was there wasn't AFib. But I presume that's because there's intermittent AFib.
Yeah, so AFib is an irregular heartbeat that can be one of two things. The fancy term for the one that comes and goes is called paroxysmal. So it can be captured. Incidentally, you may go for a checkup. The nurse might check your pulse. They may feel it's irregular. They do an ECG. There you go. There's AFib. You may go back in a week's time and get another checkup done, and you could be back in a normal heart rhythm. So atrial fibrillation is one of these heart irregular beats that comes and goes. So for us, though, if we detect atrial fibrillation, it's not always about just detecting it. Sometimes it can be about the burden and how long you have it for, and is there something else that's driving it? So it is important to have it, but it's also to understand and to know a bit more about atrial fibrillation rather than just saying, oh, there's a run of AFib. Is it significant? Is it not? Yeah, so that's how it can be there and not there all the time.
Okay, thank you for that.
Go into like
well,
we're talking about AFib on its own, so it's
no, that's fine. We did say this is going to finish at 8:30, so we've come up against the clock. Before I close, if I can just, I suppose, give my own summary of some of the take-home messages that maybe people walk away from this. I mean, starting with you, Niamh, to me, a big message here was about the fast signs and symptoms, and clearly in Norita's case, evidence that, you know, once you recognize and move quickly, this is so important. Your message about time is brain, I think, is important. And again, you were saying it's like every minute matters. And I think that's a very, very important message. And I think also your message about TIA. Sometimes people say, oh, I had a TIA, you know, is that anything to be worried about? But your point is this is a mini stroke and you need to take it seriously. And then we had Trish. Very comprehensive overview of risk factors. I thought it was interesting, Trish, and this is the same in cardiovascular disease as well. Very often think that, well, certainly with cardiovascular disease, that it's a man's disease, but as you say, postmenopausal women tend to be at a higher risk, and that's something to be aware of. Diabetes. Very often people don't make that connection. I think that if people go away with one message, diabetes is a risk factor for heart disease and stroke. I think that's a very important message. And the lifestyle, know your numbers. I think that's a key thing here. And you talked about know your numbers for you.
We seem to have lost Neil there.
We do.
Bear with us one moment, we'll get him back.
Okay.
I don't know. I lost signal there. Did you lose me? Back again?
We did.
Okay, sorry. The key message here about a stroke being a massive change and the impact, the emotional adjustment, the roller coaster. I think these are very important messages. And Norita, I think you clearly You're the classic success story in every respect, but in the context of recognizing the signs and symptoms, taking the right action, receiving the optimal care, going through the textbook case. But most important, and people have said it, you remain positive, get busy living. That's the key message here.
Yeah.
So I hope everybody who has joined us this evening has got some nugget of information from this, I think, really excellent series of presentations. I want to say a very special thank you to each of the panelists, Dr. Neil Hannon, Kyra Breen, Trish Galvin, and Norita. Really appreciate you giving your time this evening. A webinar like this doesn't just happen, and I have to say a special thanks to my colleagues, particularly Annie Costello, who put this together. But in the back room, we've had Amy, Idel, Jackie, and also just a shout out to one of our volunteers, Libby Killeen, who looks after our stroke group here, and in fact has just recorded one of our Croí Connect series, where she talks to some people about the transition from hospital to home. So that should be available on the Croí website now, and it's an interesting conversation. I'm sure people will get some benefit from that. And equally, this recording will also be available on the Croí website. That's it. We've run out of time. In fact, we've gone over time. Thank you all so much, and let's look forward to something similar again, perhaps on next World Stroke Day. Thanks, everybody. Good night.